Acid-base balance. The human body can be described as a complex system which consists of several levels of the subsystem. At the chemical level, acid and bases are some of the essential compounds upon which all biochemical process depends. Biochemical reactions which takes place in our body are extremely sensitive to even small changes in the activity of alkalinity of the environment. The acid-base hemostasis should be maintained for cellular activity, enzymatic reactions, protein conformation, CNS functions. These functions are modified when these are changed in cellular and extracellular acid-base status. For these reactions, the acid and bases that are formed constantly should be kept in balance. To understand the acid base hemostasis, a definition of some of the terms needed or explained. The bases are those which accepts proton pH. The expressed pH as a negative. pH is equal to minus log into hydrogen plus a buffer. A buffer is a solution that resists changes in pH. When a small quantities of acid or base is added, the effectiveness depends upon its pK or pKa value. The pK is the pH at which the buffer is 50% ionized, meaning that the acid concentration is exactly equal to that of the conjugate base. The buffer is very efficient at the pH plus or minus 1 around pK. The positive buffer pK is equal to 8. This buffer will have a maximum buffer capacity of between pH 5.8 and 7.8. The buffer solution is a mixture of weak acid and its base. Henderson Hasselbalch equation. pH is equal to pKa plus p plus log 10 into base by acid. In a healthy individual, the normal pH of atrial blood is 7.4 plus or minus 0.05, and that venous blood is 7.4 plus or minus 0.02. When the atrial pH rises above 7.45, then the individual is considered to have alkalosis. If the pH is below 7.35, is the individual considering to have acidosis. In a healthy subject, the pH of the blood is always between 7.35 and 7.45. The change in pH has a serious effect, and therefore the control of pH is necessary. There are two types of metabolic acid: fixed acid, lactic acid, acetic acid, beta hydroxybutyric acid, and H2SO4 and H3PO4. The fixed acid H2SO4 and H3PO4 are end products of metabolism of sulfur containing amino acid, phospholipid, nucleic acid, and phosphoprotein and phosphoglycerides. The organic acids like lactic acid and beta hydroxybutyric acid are formed during the metabolism of carbohydrate and lipid. The accumulation of acetic acid is called acetic acidosis. Normally, lactic acid produced through the anaerobic glycolysis is taken up by the liver and converted to the glucose through the Cori cycles. The pyruvate and lactate accumulation is in conditions like arsenic and mercury poisoning, and also in thiamine deficiency. The inherited enzyme pyruvate dehydrogenase deficiency also leads to lactic acidosis. Volatile acids. The carbon dioxide is a major end product in the oxidation of carbohydrate, fats, and amino acids. It has the ability to react with H2O to form H2CO3. H2CO3, which further dissociate to H plus and HCO3. The carbon dioxide can be regarded as an acid by virtue of its ability to react with H2O to form H2CO3. In vivo, it is a carbonic anhydrase in tissue of liver and kidney, which addresses the following relations: regulation of acid-base balance. The pH of plasma is 7.4, and it is normally maintained within the narrow range of 7.35 to 7.45. The blood buffer system regulates the small changes in pH. The respiratory system also does this by increasing the expulsion of carbon dioxide or conservation of carbon dioxide to regulate the blood pH. These two compensatory mechanisms cannot last for long. It is only temporary balance. The renal system maintains acid-base balance of the blood by adjusting the rate of reabsorption and excretion of H and HCO3 or HPO3, in addition to the formation of excretion of ammonia, NH3, and NH4. Blood buffer system, ECF buffer, carbonate, bicarbonate, phosphate buffer, basic protein, organic base. Bicarbonate buffer system. The most important buffer system is plasma in bicarbonate carbonate system. It accounts for 60% of buffering action in plasma and 40% in the whole body. The bicarbonate is regulated by the kidney. The acid part of carbonic acid is under the respiratory control. The buffer is most active when ratio of the salt and acid are equal according to the Anderson Hasselbalch equation. The normal plasma bicarbonate level is 24 millimolar per liter. The normal PCO2 of air but is 40 millimeter of Hg. The normal carbonic acid level is 1.2 millimolar per liter. The pKa of carbonic acid is 6.1. The substituting these value in Henderson equation. Therefore, the ratio of HCO3 to H2CO3 at pH 7.4 is 20 in a normal condition. The bicarbonate represents the alkali reserve and it is sufficient to meet the acid load during the process of a compensatory mechanism. If CO3 is 24, then H2CO3 will adjust it to 1.0. This is how the compensatory mechanism operated to bring the ratio back to 20:1. Whenever the metabolic acid is added to the blood, it reacts the basic component of the buffer system, producing salt and water, and helps to prevent the fall in blood pH. The reversal of this mechanism takes place in the event of addition of base by metabolic process. Phosphate buffer system. It maintains the intracellular buffer system. The pKa value 6.8 of this is nearer to the physiologic action. Buffer protein system. The buffering action of protein mainly depends on pKa value of ionizing side chains. The effective group in the amino chain, amino acid histidine with pKa value 6.1. Therefore, the albumin and hemoglobin, which have more histidine residue, plays an important role in buffering action in the body. Isohydric principle. The H plus respiratory regulation of acid-base plasma. The second line of defense against the acid-base disturbance is through controlling the carbon dioxide level in the lungs by either increasing or decreasing the rate of respiration. The rate of respiration is known to be controlled by the receptor present in the respiratory center, which are very sensitive to change the pH and PCO2 of oxygen. When there is a fall in plasma pH, the respiratory center is stimulated, resulting in hyperventilation, which eliminates more carbon dioxide, thus lowering H2CO3 concentration in the blood. In the same way, whenever the blood pH increases, the respiratory center are inhibited, so that the elimination of carbon dioxide is decreased by hypoventilation until the blood pH comes in control. Hemoglobin transport CO2, which is formed in the tissue, and it also serves to generate bicarbonate or alkali reserve by the activity of enzyme carbonic and anhydrase. Renal generation of pH. An important function of kidney is to generate the function by excreting either acid or basic urine. The pH of the urine remains 4.5 to 9.5 because the renal system plays a significant role in long-term maintenance of blood at pH 7.4 plus or minus 0.55. This is possible by the capacity of reabsorption, secretion, and excretion of non-volatile acids like lactic acid, pyruvic acid, HCl, phosphoric acid, and H2SO, which are produced in the body, cannot be excreted by the kidney. The first mechanism for removal of acid from the body is renal excretion. The major mechanism by which the kidney regulates the level of HCO3 in plasma or reabsorption of filtered bicarbonate, excretion, generation of new bicarbonate, and by secreting bicarbonate under the condition of chronic alkalosis, excretion of H plus ions. Another functions of a kidney is to buffer actions, thus to serve a fixed base through the production of ammonia from amino acids, which helps with the help of an enzyme glucosamine. Whenever there is excess acid production, the ammonia produces is also increases, which combines with H plus to form NH4, which is excreted as a NH4Cl. This occurs in event of acidosis. When alkali is in excess, the H plus is reabsorbed into the cell in exchange of Na, and acid-base disorder. Acid-base disorder results from variety of pathological conditions. The normal pH of the blood is referred as a euphemia. If the pH of the blood is more than the normal range, it is termed as alkalemia, and the condition is called alkalosis. The pH is lesser than normal range is called as acidemia, and the condition is called acidosis. There are two reasons for pH abnormality in blood, which are metabolic or respiratory causes. Metabolic causes are responsible for the metabolic acidosis and alkalosis. The respiratory causes are mainly responsible for respiratory acidosis and alkalosis compensation. The body's acid-base balance is tightly regulated. Several buffering actions exist which reversibly bind hydrogen ions and slow down any change in pH. Extracellular buffer, including bicarbonate and ammonia, while proteins phosphate acts as an intracellular buffer. The bicarbonate buffering system is especially key as a carbon dioxide can be shifted through carbonic acid to hydrogen ions and bicarbonate as a H1. The kidney or slow to compensate acid base inhibitor that overcomes buffering system can compensate in a short term by change of rate of ventilation. This alter concentration of carbon dioxide in the blood. For instance, if the blood pH drops too low, the body will compensate by increasing the breathing and expelling carbon dioxide. The kidney or slower to compensate, but renal psychology has several powerful mechanisms to control pH by excretion of excess acid or bases. In process of acidosis, tubular cells reabsorbs more bicarbonate from the tubular fluid. The collecting duct cells secretes more hydrogen and generates more bicarbonate, and aminogenesis leads to increased formation of ammonia buffer. In response to alkalosis, the kidney may excrete more bicarbonate by decreasing hydrogen ion secretion from the tubular epithelial cells and lowering rate of glutamine metabolism and ammonia excreted. This metabolism acidosis, this is one of the common acid base distribution. In this condition, the HCO3 concentrations reduce. This is due to the increased production of acids. These acids dissociate to give H plus ions with the difference of HCO3. Causes of uncontrolled diabetes mellitus, lactic acidosis. This is one of the number of causes of particularly tissue anoxia. In acute hypoxia, the conditions such as respiratory failure or cardiac arrest, lactic acidosis developed immediately. Lactic acidosis may be caused by liver disease. The presence of lactic acidosis can be determined by plasma lactate. The diabetic ketosis, the ketoacidosis is a metabolic state associated with a higher concentration of ketone bodies formed by the breakdown of fatty acids and deaminations of amino acids due to the lack of insulin. The two common ketone produced in humans are acetic acid and beta hydroxybutyrate. Ketoacetic acid is the most common in untreated type 1 diabetes mellitus when the liver breaks down fat and proteins is responsible to a perceived need for respiratory substrate. The chronic renal failure intoxication, the organic acids, sulfates, metformin. Metabolic acidosis is also due to the ingestion of fat acids like ammonia chloride and ammonia port after detoxified leaves behind the H plus. It also occurs in diarrhea, which leads to loss of HCO3 from the intestinal fluid. The primary compensatory mechanism in the metabolic acidosis is through the hyperventilation that removes carbon dioxide. The rapid and gasping respiratory pattern is known as a Q small breathing. There is also elimination of acid in urine and urinary ammonia is increased. Metabolic alkalosis. This condition occurs due to the gain of more HCO3. This occurs in vomiting, ingestion of bicarbonate in the treatment of peptic ulcer, potassium depletion. Hypokalemic alkalosis is caused by the kidney response to an extreme lack or loss of potassium, which can occur when people take certain diuretic medications. The compensatory mechanism is through the hypoventilations to prevent carbon dioxide loss. The secondary compensatory mechanism by increasing the excretion of bicarbonate by kidney. Respiratory acidosis, the retention of carbon dioxide leads to change in bicarbonate. The ratio of HCO3 and carbon dioxide decreases. This is caused by the hypoventilation, which occurs due to the obstruction of respiration, that is pneumonia, asthma, antidepressant of respiratory centers, in morphine, bicarbonate poisoning, and alcohol ingestion. The primary compensatory mechanism is reabsorption of bicarbonate from the kidney. respiratory alkalosis. This is caused by the hyperventilation that leads to the reduced carbon dioxide of the H3O level also slightly varies. This occurs when respiration is stimulated as in fever, but hot bath, lack of oxygen at a high altitude and increased environmental temperature. The compensatory mechanism is by increasing the excretion of HCO3 by kidney. A mixed acid disorder. The mixed acid disorder occurs when there is more than one primary acid base disturbance present simultaneously. They are frequently seen in hospitalized patients, particularly in critically ill. Mixed acid base disorder occurs when expected compensatory response does not occur. The compensatory response occurs, but level of compensation is inadequate or too extreme. Whenever the PCO2 and HCO3 becomes abnormal in opposite direction, in simple acid-base disorder, the direction of a compensatory response is always the same as the direction of initial abnormal changes. The pH is normal, but PCO2 or HCO3 is abnormal. The anionic gap metabolic acidosis. If the change in bicarbonate level is not proportional to the change of anion gap, more specifically, if the delta ratio is greater than 2 or less than 1. In simple acid-base disorder, the compensatory response should never return the pH to normal. If that happens, the suspected mixed acid-base disorder usually produces atrial blood gas results that could potentially be explained by other mixed disorder. Oftentimes, the clinical picture will help the distinguish. It is important to distinguish mixed acid-base disorder because management will depend on the acute diagnosis. Chronic respiratory acidosis with a superior impulse acute respiratory acidosis, acute exacerbation of COPD secondary to acute pneumonia. The COPD patient with a worsening hypoventilation secondary to oxygen therapy or sedative administration. The chronic respiratory acidosis and anion gap metabolic acidosis, COPD patients who develop shock and lactic acidosis. The chronic respiratory acidosis and metabolic acidosis, example pulmonary inefficiency and diuretic therapy. COPD patients treated with steroid or ventilations, respiratory alkalosis and metabolic acidosis, salicylic intoxication, gram-negative sepsis, acute cardiopulmonary arrest, severe pulmonary edema. Anion gap. The sum of cations and anions in extracellular fluid is always equal to the maintain the electrical neutrality. 95% of cation were maintained by Na plus and K plus. The chloride and bicarbonate accounts for 86% of anions. These are commonest to measure electrolyte, and hence there is a difference between cations and anions. The difference between the cation and anion or unmeasured anions constitutes the anion gap, which is due to the presence of phosphorus, SO4, SPO4 and organic acid salts. The difference between the sodium potassium chloride and bicarbonate is normally between 12 plus or minus 5 milliequal per liter. The measurement of anion gap is extremely useful in clinical assessment with acid base disorder. Assessment of acid base analysis, blood gas analyzer which measures pH, PCO2 and PO2 by means of electrode is usually used to measure acid base parameter of atrial blood. Heparinase blood is collected and directly introduced into the analyzer. The blood should be analyzed within 20 minutes of collection. There should not be any contact of collected blood with the external air during the either collection of or analysis procedure.